All right, so let's imagine this. You're feeling a little run down, blood pressure's up, and then your doctor tells you your potassium is low. You might think, okay, easy fix.
Right, you just pop a potassium pill.
But what if I told you those, like, seemingly simple symptoms could be a sign of a much bigger issue?
Yeah, it's like a medical mystery.
Yeah.
And today we're doing a deep dive into hypertension and hypokalemia, specifically when they occur together. Because those two things together might actually point to a condition called primary aldosteronism.
Okay, so primary aldosteronism, for those of us who are not doctors, what exactly are we talking about here?
So basically, it's a condition where your adrenal glands, which are these little hormone powerhouses sitting on top of your kidneys, they decide to go a little rogue,
Mm-hmm.
and they produce too much of a hormone called aldosterone.
Okay, so too much aldosterone, what does that actually do to the body? Why is that a problem?
Well, that excess aldosterone can really do a number on your body.
Mm.
It can lead to that persistent high blood pressure, the potassium depletion that you mentioned, and even, more serious problems down the line if it's not caught.
So you're saying there's this condition out there that causes high blood pressure, which is a major health concern. We all know that, and it's often missed.
Yeah, and the reason it's often missed is because those classic signs that we learn about, like in med school, the high blood pressure and the low potassium,
Yeah.
they're not always present.
Really?
Yeah, in fact, studies have shown that a lot of people diagnosed with primary aldosteronism
Huh.
actually have normal potassium levels.
So you can have this condition and your potassium is totally fine.
It happens more often than you might think. And that's one of the big reasons why it's so often missed.
So how are you supposed to know? It's like a mystery with missing clues.
Exactly.
So that's why we're here.
Yeah, we're going to try to give you the information you need so that you can understand this condition and advocate for your own health.
So let's talk about some of the potential causes of these
That
symptoms.
sounds good.
Like we said, we have primary aldosteronism, but then within that, we have a couple of different subtypes.
Yeah, we've got the aldosterone-producing adenoma, which is like a tiny little overachieving factory on one of your adrenal glands, just pumping out way too much aldosterone. And then there's bilateral idiopathic hyperaldosteronism.
Wow, that's a mouthful.
I know, right?
What does that even mean?
Basically, it means both adrenal glands are enlarged, and they're both overproducing aldosterone. And the idiopathic part just means we don't always know the exact cause.
So it's a bit of a mystery still. So
Yeah.
we've got these two different types under the primary aldosteronism umbrella,
Uh-huh.
and they need to be treated differently.
Exactly. It's really important to figure out which subtype is causing the problem because an adenoma often needs surgery,
Mhm.
whereas bilateral hyperplasia is usually managed with medication.
Okay, so that makes sense. But we also have to think about secondary aldosteronism, right?
Right.
What is that?
So in secondary aldosteronism, the adrenal glands aren't actually the main problem.
Mm.
Something else is basically making them overproduce aldosterone. It's like they're getting bad intel from somewhere else in the body.
So they're not the real culprit, they're just reacting.
Yeah, exactly. They're just responding to a false alarm.
So what are some of the things that could trigger that false alarm?
One common culprit is something called renovascular disease.
Okay.
This is where the arteries that supply blood to the kidneys get narrowed. So it's like the kidneys are sending out an SOS like, help, we're not getting enough blood flow. And the adrenal glands hear that, and they try to help by pumping up the aldosterone to raise blood pressure.
But that constant overdrive, it must put a strain on the adrenal glands. Are there long-term consequences from that?
That's a great question, and it definitely highlights why it's so important to find the root cause and get the right treatment. And we'll talk about that more later on. But for now, let's finish up our list of suspects.
Okay, so who else is involved in this medical drama?
So we have Cushing syndrome, which
Hmm.
is a hormonal disorder that can sometimes look like primary aldosteronism.
Okay.
And then, believe it or not, we have licorice.
Wait, licorice, like the candy?
Yep.
Seriously?
I know it sounds strange, but licorice has a compound that can actually mimic the effects of aldosterone in the body.
Really?
Yeah, so you can actually get similar symptoms like high blood pressure and low potassium just from eating too much licorice.
Well, maybe go easy on the licorice whole sorts.
Exactly.
So we've got some pretty common things. We've got some pretty strange things. Are there any more obscure possibilities we should be thinking about?
Well, there are also some rare genetic conditions that can disrupt the body's balance of salt and potassium.
Okay.
These are much less common, but it's important to be aware of them because they need a totally different treatment approach.
So we've got a whole cast of characters here,
Mhm.
from out-of-control adrenal glands to misleading licorice.
Right.
This is one complicated case.
Yeah, it is.
But don't worry, we're going to break down this whole diagnostic puzzle step by step. Hopefully by the end of this deep dive, you'll feel like a medical detective yourself.
Exactly. All right, so we've met our suspects now. Let's talk about how we actually investigate this whole thing. How do doctors actually figure out what's causing your hypertension and hypokalemia?
Yeah, because it sounds like a pretty complicated diagnostic maze.
It can be,
Hmm.
but luckily we have some tools to help us navigate it.
Okay, so what's the first step?
Well, the first clue usually comes from a blood test.
Okay, a blood test, so something simple.
Yeah, but this blood test isn't just looking at your basic stuff. It's looking for two key players.
Okay.
We're talking about plasma renin activity, or PRA, and aldosterone concentration.
Okay, so PRA and aldosterone, what do those tell us?
Well, imagine renin and aldosterone as like two parts of a seesaw that's trying to keep your blood pressure balanced.
Okay, I like that analogy.
So renin is released by your kidneys when your blood pressure drops,
Okay.
and it kicks off this whole chain reaction that ultimately leads to the production of aldosterone.
By those rogue adrenal glands?
Right. And aldosterone's job is to help your body hold on to salt and water, which in turn raises your blood pressure back up.
So it's like a built-in blood pressure control system.
Exactly.
But how does this help us solve our mystery?
Well, in primary aldosteronism, remember the adrenal glands are kind of acting independently. They're pumping out aldosterone even when the renin signal is low.
So if you see low renin, that's a red flag.
Exactly. Low renin could be a sign that primary aldosteronism is the culprit. On the other hand, if both renin and aldosterone are high, that might point us towards a secondary cause where something else is driving that aldosterone production.
Like those false alarms we talked about.
Exactly. But it gets even more interesting. Doctors don't just look at those levels individually, they also look at the ratio between the two.
Ratio.
Yeah, it's called the PACE-PRA ratio.
Okay, so what does that tell us?
This ratio is like a spotlight that can help us narrow down our list of suspects. A high PACE-PRA ratio with high aldosterone and low renin that shines the spotlight directly on primary aldosteronism.
So it's basically saying those adrenal glands are overproducing aldosterone even though they shouldn't be.
Right. But if the ratio is low, meaning both renin and aldosterone are low, then we might start thinking about some of our other suspects.
Like Cushing's syndrome or even the licorice.
Exactly. So this ratio can really help us figure out where to focus our investigation.
So just from a simple blood test, we can start to get some answers.
Yeah.
That's pretty amazing. But is it enough to make a diagnosis?
It's a strong clue, but not quite a slam dunk. We need more evidence to confirm our suspicions.
Okay, so what happens next? What other tests do we need?
Well, one option is a test called the oral sodium loading test.
Oral sodium loading, so I get to eat a bunch of salty snacks.
Uh-huh. Not exactly. It's a little more controlled than that. Basically, you'd work with your doctor to follow a high sodium diet for a few days.
Okay.
And then they'd check your aldosterone levels to see how your body responds.
So they're basically challenging your system with a sodium overload to see how those adrenal glands react.
Exactly. And if they don't suppress aldosterone production, like they should, that's a big sign that primary aldosteronism might be at play.
Okay, that makes sense. Are there any other tests they might do?
Yeah, there's also the saline infusion test.
Okay.
It's similar to the oral sodium loading test, but instead of eating a lot of salt, you get an IV infusion of saline solution.
Okay.
It's a faster way to increase your sodium levels. And again, the goal is to see if those adrenal glands respond correctly.
So both of these tests are basically stress tests for the adrenal glands.
Exactly. We're trying to see if they're behaving like they should.
Okay, so let's say one of these tests confirms primary aldosteronism.
Right.
Are we done then? Do we know what's causing it?
We're getting closer, but remember, we still have those two main subtypes of primary aldosteronism.
Right, the adenoma and the hypoplasia.
Yeah, and those two conditions need to be treated differently.
So how do we figure out which one it is?
Well, that's where we usually bring in some imaging. A CT scan of the adrenal glands is usually the first step.
Okay, so we're looking for that rogue factory.
Right. We want to see if there's a tumor on one of the adrenal glands, we would point towards an adenoma.
But you said earlier that sometimes those scans can be misleading.
They can be, unfortunately. You see, sometimes an adenoma might have another nodule on the other adrenal gland that's not producing aldosterone.
Okay.
So it might look like bilateral hyperplasia on the scan, even though it's not.
So what do they do if the scan isn't clear?
Well, in those cases, they might do a more specialized procedure called adrenal vein sampling.
Adrenal vein sampling.
It sounds a little intimidating, but it's actually a pretty safe procedure, and it's considered the gold standard for differentiating between adenoma and hyperplasia.
Okay, so how does it work?
Basically, a radiologist uses imaging guidance to insert these tiny little catheters into the veins that drain blood from your adrenal glands.
Wow, so they're going right to the source.
Yeah, and then they take blood samples from each adrenal vein and they compare the aldosterone levels. So if someone has an adenoma, the vein draining the side with the tumor will have a lot more aldosterone.
Okay.
But if both veins have similar levels of aldosterone, that points towards hyperplasia.
So it's like the ultimate tiebreaker.
Exactly. It gives doctors a definitive answer so they can choose the right treatment.
No, we can't forget about those rare genetic forms of primary aldosteronism. You mentioned those earlier.
Right.
But they're so rare, are they really that important to think about?
Well, they might be rare overall, but they're incredibly important for the people who have them. And they really highlight the role of family history in diagnosis.
Okay.
So if someone is diagnosed with primary aldosteronism at a young age, or if they have a family history of the condition, then genetic testing might be recommended.
So knowing about these rare forms could actually change the treatment plan.
Exactly. It just goes to show you that what seems like a simple case of high blood pressure could actually have a much more complicated backstory.
Wow. So we've gone deep into this diagnostic maze.
We have.
But before we wrap up, I want to go back to something you said earlier about the consequences of misdiagnosis. What happens if primary aldosteronism goes undetected?
Yeah, that's a really important question, and it leads us to one of the biggest takeaways from this whole deep dive.
Yeah. So when primary aldosteronism is missed, people often just end up getting treated for regular high blood pressure for years and years, sometimes even decades, without ever really addressing that underlying cause.
So they're being treated, but not for the right thing.
Exactly. And that can have some pretty serious consequences down the road.
Like what kind of consequences are we talking about?
Well, studies have shown that people with undiagnosed primary aldosteronism have a much higher risk of developing heart problems.
Heart problems like what specifically?
We're talking about heart attacks, strokes, heart failure, that kind of thing.
So some pretty serious stuff.
Yeah. And it's not just the heart. Remember, aldosterone affects other parts of the body, too. Like, its main job is to regulate salt and potassium levels.
So when it's constantly high, it can lead to potassium depletion, even if it wasn't obvious on the initial tests.
And low potassium can cause problems, too, right? I'm thinking muscle cramps, fatigue, things like that.
Definitely. But it can also be much more serious than that. Chronic hypokalemia can contribute to all sorts of problems like muscle weakness, irregular heartbeat, kidney problems, even bone loss.
Wow. So we're talking about a whole cascade of potential health issues.
Right.
And it all stems from this one condition that often flies under the radar.
Exactly. That's why we're doing this deep dive.
Yeah.
To try to raise awareness so people can advocate for themselves and ask the right questions.
Because if you don't know what to look for, you might not even think to ask.
Right. So if you're dealing with high blood pressure, that just won't quit. Especially if you have other symptoms too, like you said, the fatigue or muscle weakness, or even just a feeling that something's off. Don't be afraid to bring it up with your doctor.
And it's important to remember, even if your potassium levels are normal, it doesn't rule out primary aldosteronism.
Right. And don't hesitate to ask about those specific tests, like the PAC-PRA ratio or the other ones we talked about.
Especially if you have a family history of high blood pressure or other risk factors.
Exactly. Like we said before, it's a medical mystery.
And sometimes you have to be a bit of a detective to get to the bottom of it.
Right. And the good news is, once primary aldosteronism is diagnosed, it can often be treated effectively.
So you can reduce the risk of all those complications we talked about.
Exactly.
So this deep dive has really been about so much more than just one condition.
It is.
It's about being proactive and taking control of your health.
It really is about being your own best advocate.
Well said. And for everyone listening out there, if you're feeling a bit overwhelmed by all this information, just remember, knowledge is power.
It is.
Take what you've learned today, do some more research if you want, and have a conversation with your healthcare provider.
And if you enjoyed this deep dive into primary aldosteronism, stay tuned because we have a lot more medical mysteries to explore in future episodes.
So until next time, keep learning, keep questioning, and keep taking charge of your health.